Welcome. In this session and the next, we'll be discussing about the various patterns of vertical strabismus. As we have found in the previous session and as we will be discussing further in this session, vertical strabismus can be associated with torsional strabismus and pattern deviations. These patients usually have oblique muscle dysfunctions as their underlying cause. And in these patients, we will find horizontal incomitance of their vertical deviation as we will be discussing in this session. And vertical strabismus from causes other than oblique muscle dysfunctions usually do not have associated torsional strabismus or pattern deviations, and in these patients the vertical deviation between the two eyes is found to be horizontally committant. So in a vertical deviation, we find vertical misalignment of the two eyes with one eye being higher than the fellow eye, and usually the strabismus is called as a hypertropia of the higher eye. And as we have said, vertical strabismus can be associated with torsion of the eyes, and torsion can be detected by fundoscopy, in which we'll find the fundus of the eye as being tilted, as shown in this diagram, with this figure showing extorsion of the left eye and this figure showing intorsion of the left eye. Blind spot mapping can also help us to detect torsion. When we perform the visual field test on an eye with extortion, in the report we'll find that the blind spot is located below the horizontal meridian corresponding to the superior displacement of the optic disc in an extorted eye. And in an intorted eye, the blind spot will be located above the horizontal meridian corresponding to the inferior displacement of the optic disc in an eye with intorsion. Double Maddox rod test and Lancaster red-green test also helps us to detect as well as measure the amount of torsion, and we have discussed these tests in the session on motor evaluation of strabismus. Apart from oblique muscle dysfunction, torsional deviation can also be caused by cyclorotated position of the muscle pulleys, which is an unusual cause of torsional deviation and is found particularly in patients with craniosynostosis and slanted palpebral fissures. And MRI can help us in diagnosing the cyclorotated position of the muscle pulleys in these patients. Vertical strabismus can be broadly classified into vertical deviations with horizontal incomitance and vertical deviations with horizontal commitance. In this session, we will be discussing the vertical deviations with horizontal incomitance, and in the next session, we will be discussing the vertical deviations with horizontal commitance. In vertical deviations with horizontal incomitance, the vertical deviation between the two eyes is different in right gaze and left gaze, and this difference in the vertical deviation in right and left gaze positions is more than 10 prism diopters. Horizontally incomitant vertical deviations commonly occur due to dysfunction of oblique muscles, and this dysfunction of oblique muscles can be oblique muscle overaction, oblique muscle palsy, or oblique muscle restriction. And uncommonly, horizontally incomitant vertical deviations can occur from cyclorotational heterotopia of muscle pulleys. Since horizontally incomitant vertical deviations occur due to dysfunction of oblique muscles, torsional strabismus and pattern strabismus are commonly associated with horizontally incomitant vertical deviations. Overelevation in adduction, as seen in this diagram, is most commonly caused by inferior oblique overaction, and this is very important to remember. Overelevation in adduction is less commonly caused by excyclorotated position of the muscle pulleys, which can be found in craniofacial syndromes, and this can be associated with downward slanting palpebral fissure in which the horizontal level of lateral canthus is below the horizontal level of medial canthus. So this diagram shows a patient with inferior oblique overaction of the right eye, with the right eye showing overelevation in adduction. But in a primary position or in the abducted position, the right eye will not show overelevation, demonstrating the horizontally incomitant nature of this vertical deviation. Overelevation in adduction can be caused by restriction of the contralateral inferior rectus muscle and anterior transposition surgery of contralateral inferior oblique muscle, because in both these situations there will be limited elevation of the contralateral eye in abduction and appearance of overelevation in adduction of the ipsilateral eye. Overdepression in adduction, as shown here in this diagram, is most commonly caused by superior oblique overaction, and this is also very important to remember. Less commonly, overdepression in adduction is caused by an encyclorotated position of the muscle pulleys, which can occur in craniofacial syndromes, and this can be associated with upward slanting palpebral fissure in which the horizontal level of the lateral canthus is above the horizontal level of the medial canthus. Overdepression in adduction can also occur following restriction of the contralateral superior rectus muscle, which will limit depression of the contralateral eye in its abducted position, and thus the ipsilateral eye will appear to be overdepressed in its adducted position. There are two scenarios: large angle exotropia and Duane's syndrome with upshoots and downshoots, each of which will show overelevation in adduction in certain points in time and overdepression in adduction at other points in time. This occurs in large angle exotropia due to a tight lateral rectus muscle, and with a tight lateral rectus muscle, when the eye is adducted, it can slip over or below the tight lateral rectus muscle, causing overelevation or overdepression in adduction. Inferior oblique overaction is the commonest cause of overelevation in adduction, and inferior oblique overaction can be primary, which is usually found in patients with infantile strabismus, either esotropia or exotropia. But in these patients, the inferior oblique overaction has an onset after the first year of life. Secondary overaction of the inferior oblique muscle is associated with palsy of the ipsilateral superior oblique muscle, which is the antagonist of the inferior oblique muscle. It can also occur after palsy of the contralateral superior rectus muscle, which is the yoke of the ipsilateral inferior oblique muscle. The clinical features of inferior oblique overaction include overelevation in adduction, cyclotorsion, and a V-pattern strabismus. The overelevation in the contralateral gaze is accentuated in the up and contralateral gaze, and in patients with bilateral inferior oblique overaction, there will be hypertropia of the right eye in left gaze and hypertropia of the left eye in right gaze. Clinical features which are absent in primary overaction of inferior oblique muscle but can be found in secondary overaction of inferior oblique muscle are vertical deviation of the affected eye in the primary position and a positive 3-step test. This is because the secondary overaction of the inferior oblique is most commonly caused by palsy of its antagonist, the ipsilateral superior oblique muscle, and these two are the clinical features of superior oblique palsy. We will be discussing superior oblique palsy in this session. Treatment of primary inferior oblique overaction is weakening of the overacting inferior obliques with recession, myotomy or myectomy. We will be defining these procedures in the session on extraocular muscle surgery. Anterior transposition of inferior oblique also weakens the inferior oblique muscle and is a preferred procedure when there is an associated DVD, which is also taken care of by anterior transposition of the inferior oblique muscle. We can recall that inferior oblique overaction and dissociated vertical deviation are both associated with infantile horizontal strabismus, and weakening of the overacting inferior oblique in infantile horizontal strabismus patient with primary inferior oblique overaction is done in the same sitting as the correction of the horizontal strabismus. Treatment of secondary inferior oblique overaction, which usually occurs from superior oblique palsy of the same eye, will be discussed along with superior oblique palsy. Superior oblique overaction is mostly primary because ipsilateral inferior oblique palsy is an uncommon entity. The clinical features of superior oblique overaction include overdepression of the involved eye in adduction, in cyclotorsion, and an A pattern strabismus. The overdepression in contralateral horizontal gaze of the affected eye in adduction is accentuated in down and contralateral gaze. And we can also find vertical deviation in patients with unilateral or asymmetric bilateral superior oblique overaction. This contrasts with primary inferior oblique overaction, in which vertical deviation in the primary position is uncommon. Treatment of primary superior oblique overaction is weakening of the overacting superior oblique muscle by tenotomy or with spacers. In tenotomy, the tendon is cut, and in spacers, the tendon is cut and is reattached with a spacer in between the cut ends. And we must remember that patients with overelevation or overdepression in adduction due to cyclorotation of muscle pulleys, the uncommon cause of overelevation or overdepression in adduction, respond poorly to oblique weakening procedures. After discussing the overactions of the oblique muscles, we now come to palsies of the oblique muscles. Superior oblique palsy is the most common single cyclovertical muscle palsy, because it is the only one among the four cyclovertical muscles of each eye to be supplied by a cranial nerve, the fourth cranial nerve, which in turn innervates only one extraocular muscle. And four patterns of superior oblique palsy: unilateral superior oblique palsy, bilateral superior oblique palsy, masked bilateral superior oblique palsy, and congenital superior oblique palsy, are important to differentiate from one another. Superior oblique palsy can be congenital or acquired. Congenital superior oblique palsy is said to be due to a congenital defect of the trochlear nerve or the tendon trochlea complex, and congenital superior oblique palsy usually progress and almost always requires surgery. It is important to note that a superior oblique palsy which is congenital in origin may become symptomatic only on adulthood because of decline in vertical fusion amplitudes from childhood to adulthood. Acquired superior oblique palsy is most commonly due to closed head trauma. Less commonly, CNS lesions which can be vasculopathic or compressive or direct trauma to the trochlea and the tendon can cause acquired superior oblique palsy. It is important to recognize the features suggesting congenital superior oblique palsy. Childhood photographs of the patient will show compensatory head tilt. Because of the compensatory contralateral head tilt, there will be hypoplasia of the ipsilateral face. These patients have large vertical fusional amplitudes, and this is very important in diagnosing a patient with congenital superior oblique palsy. And in patients with congenital superior oblique palsy, history of a significant closed head trauma or signs of CNS lesions are absent, and amblyopia is a rare occurrence. Neuroimaging is required in acquired superior oblique palsy in the absence of a history of closed head trauma, which will suggest either a microvasculopathic lesion or a compressive lesion. Patients with unilateral superior oblique palsy will have a vertical diplopia which is more in down gaze, with this vertical diplopia increasing on ipsilateral head tilt and contralateral gaze. But encyclodiplopia due to excyclotorsion is uncommon in unilateral superior oblique palsy, which, as we will be discussing later, is common in bilateral superior oblique palsy. And we'll find that in bilateral superior oblique palsy, vertical diplopia is less common, particularly if the bilateral superior oblique palsy is symmetrical. Typically, the patient assumes a contralateral head tilt to reduce the vertical diplopia. Contralateral head tilt induces excyclotorsion of the affected eye to keep the eye in the primary position, and the two extorters, inferior oblique and the inferior rectus, both being normal, neutralize their vertical actions without any vertical diplopia. But when the head is tilted ipsilaterally, encyclotorsion of the affected eye will be induced to maintain the eye in the primary position, and among the two encyclotorters, the superior rectus being normal and the superior oblique being weak, the vertical action of the superior rectus being elevation will not be neutralized by the weak depression of the palsied superior oblique muscle, increasing the hypertropia of the affected eye and increasing vertical diplopia. However, some patients may take up ipsilateral head tilt, increasing the vertical separation of the two images, and ignore one of them. Signs of unilateral superior oblique palsy include hyperdeviation of the affected eye in primary position, which increases in contralateral gaze and in ipsilateral head tilt. But adduction testing with the fellow eye covered may show normal action of the palsied superior oblique muscle. X-cyclorotation can be detected by bilateral Maddox rod test, and this test also helps in measuring the X-cyclotorsion. But as we have mentioned, X-cyclotorsion is less severe than in bilateral superior oblique palsy. When the affected eye with superior oblique palsy is used to fixate a target in the up and contralateral direction, there will be hypertropia of the contralateral eye. This is because in the adducted position of the eye, the inferior oblique muscle is the main elevator of the eye, but the inferior oblique muscle requires decreased innervation because its antagonist, the superior oblique muscle, is palsied, and consequently, because of the decreased innervational requirement of the ipsilateral inferior oblique, the yoke of the ipsilateral inferior oblique, that is the contralateral superior rectus muscle, which elevates the contralateral eye in its abducted position, also receives decreased innervation according to Heading's law, and because of this decreased innervation to the contralateral superior rectus, there is hypotropia of the contralateral eye, and this is called inhibitional palsy of the contralateral antagonist. Although contralateral antagonist is a conflicting term, because by definition the term antagonist refers to a muscle in the same eye with opposite action. Spread of commitance occurs in long-standing superior oblique palsy, like palsy of any other extraocular muscle. Spread of commitance means decrease in the difference of deviation in different positions of gaze as found in paralytic strabismus, and because of which the incomitant nature of the strabismus becomes more and more like a comitant strabismus, in which the deviation between the two eyes is the same in all positions of gaze. And spread of commitance in superior oblique palsy occurs due to contracture of ipsilateral superior rectus muscle because of long-standing hypertropia of the affected eye, and contracture of contralateral inferior rectus muscle because of long-standing hypotropia of the fellow eye. Bilateral superior oblique palsy is usually due to a closed head trauma, and less commonly bilateral superior oblique palsy can be congenital in origin. Bilateral superior oblique palsy can be asymmetric in nature, and in any patient presenting with unilateral superior oblique palsy, we need to exclude palsy of the superior oblique muscle of the contralateral eye. The clinical features of bilateral superior oblique palsy includes minimal vertical deviation between the two eyes in primary position, particularly in a symmetrical bilateral superior oblique palsy, because hypertropia of each eye neutralize each other, and we'll find right hypertropia in left gaze and left hypertropia in right gaze in bilateral superior oblique palsy. Also, we'll find right hypertropia in right head tilt and left hypertropia in left head tilt in bilateral superior oblique palsy. And because of these two features, the three-step test is said to be positive in each eye of a patient with bilateral superior oblique palsy. In bilateral superior oblique palsy, X-cyclotorsion is significant as compared to a patient with unilateral superior oblique palsy, and this is because X-cyclotorsion of each eye is additive, unlike the vertical deviation of the two eyes which neutralize each other. And because of this significant X-cyclotorsion, patients with bilateral superior oblique palsy perceive more encyclodiplopia than patients with unilateral superior oblique palsy. V pattern is also a feature of bilateral superior oblique palsy. So we say that minimal vertical deviation between the two eyes in the primary position, hypertropia of each eye in contralateral gaze, significant X-cyclotorsion, and V pattern strabismus make the clinical features of superior oblique palsy resemble the clinical features of inferior oblique overaction. But in contrast to patients with superior oblique palsy, patients with primary inferior oblique overaction will not show right hypertropia in right head tilt, and left hypertropia in left head tilt, and so will be negative on the 3-step test, and will also not show a chin down position to reduce vertical diplopia and excyclotorsion. So if we list the contrasting features of bilateral superior oblique palsy and unilateral superior oblique palsy, hypertropia in primary gaze is usually present in patients with unilateral superior oblique palsy, but may be absent in patients with bilateral superior oblique palsy if the bilateral superior oblique palsy is symmetric. And in patients with bilateral superior oblique palsy, excyclotorsion and consequently encyclodiplopia as well as V pattern is more significant than in patients with unilateral superior oblique palsy. Patients with bilateral superior oblique palsy usually take up a chin down position, whereas patients with unilateral superior oblique palsy usually takes up a contralateral head tilt position. And the 3-step test will be positive on both the sides in bilateral superior oblique palsy, but will be positive on the affected side only in unilateral superior oblique palsy. A masked bilateral superior oblique palsy is a markedly asymmetric bilateral superior oblique palsy appearing as a unilateral superior oblique palsy. And the most common cause of masked bilateral superior oblique palsy is the same as the most common cause of bilateral superior oblique palsy, that is closed head trauma. And the superior oblique palsy in the less affected eye can be detected by excyclotorsion of the fundus, esotropia between the two eyes in down gaze, and an overdepression in adduction, even if minimal, can usually be detected. Superior oblique palsy with small, almost comitant vertical deviation without a significant torsional component can be corrected by prisms neutralizing the vertical deviation in primary position and down gaze. Indications for surgery in superior oblique palsy include an abnormal head position and significant diplopia. In traumatic superior oblique palsy, surgery should be deferred for at least 6 months after onset to allow the traumatized muscle to recover spontaneously from the palsy. And in long-standing superior oblique palsy, particularly since childhood, undercorrection is well tolerated because of the large vertical fusional amplitudes, but overcorrection with a reversed vertical diplopia is poorly tolerated because fusional amplitudes for the reversed diplopia are not well developed. For determining the recommended treatment, NAB classified superior oblique palsy into 7 classes: lateral superior oblique palsy, and the remaining are unilateral superior oblique palsy. In class 1 patients, hypertropia is greatest in contralateral upgaze, suggesting secondary inferior oblique overaction to be significant. Inferior oblique weakening is the procedure recommended. But if hypertropia is greatest in contralateral downgaze, suggesting superior oblique weakness as the predominant factor, superior oblique tightening is done by tucking. And in these patients, the superior oblique tendon is usually found to be lax by force duction testing intraoperatively, and superior oblique tightening by tucking should be done only when the tendon is found to be lax by this method. In class 3 patients, hypertropia is greatest and similar in all contralateral gaze positions, that is horizontal, up and down. And if such a vertical deviation is small, then inferior oblique weakening is usually performed. But if such a deviation is larger, additional muscles will need to be operated on. A combined weakening of the inferior oblique along with strengthening of the superior oblique is very effective, but can cause an iatrogenic Brown syndrome. Alternatively, the contralateral inferior rectus muscle can be recessed along with superior oblique tightening or inferior oblique muscle weakening. In class 4 patients, hypertropia is greatest and similar in all contralateral gaze positions, that is horizontal, up and down, and also all down gaze positions, that is straight, right and left. And in addition to oblique muscle surgery, they need recession of ipsilateral superior rectus muscle if there is restriction of the superior rectus muscle. Otherwise, recession of the contralateral inferior rectus muscle is done, which reduces the relative hypotropia of the contralateral eye. In class 5 patients, hypertropia is greatest and similar in all down gaze positions, that is straight, right and left. And this is an uncommon situation, and tightening of superior oblique is required, in addition to which, if there is restriction of the superior rectus muscle because of long-standing hypertropia, the superior rectus muscle should be recessed. Otherwise, recession of the contralateral inferior rectus muscle is done, which decreases the relative hypotropia of the contralateral eye. Class 6 refers to bilateral superior oblique palsy, which we will be discussing next, and in class 7 palsies, there is combined restriction as well as palsy of the superior oblique muscle, which usually follows dog bite injury and frontal sinus surgery. And in these situations, it is recommended to first relieve the restriction and then correct the palsy as required later. If bilateral superior oblique palsy is asymmetric, hypertropia in primary gaze is significant, surgical decision is based as for unilateral superior oblique palsy just discussed. If a bilateral superior oblique palsy is symmetric, the vertical deviation in primary position is minimal as we have seen. And in a symmetric bilateral superior oblique palsy, if there is hypertropia in contralateral gaze to either side, bilateral inferior oblique weakening is recommended. But if in addition to hypertropia in contralateral gaze to either side, there is excyclotorsion and V pattern, a bilateral superior oblique tightening is preferred. But if the bilateral symmetric superior oblique palsy has predominantly excyclotorsion, with the hypertropia in contralateral gaze to either side being minimal, a bilateral Harada-Ito procedure is done, in which the anterior fibers of the superior oblique tendon is transposed anteriorly and laterally to improve the intorsion action of both superior oblique muscles. Inferior oblique palsy is an uncommon entity which can be due to a congenital palsy of the muscle or due to traumatic injury to the muscle. Clinical features of inferior oblique palsy include a positive 3-step test which will show hypertropia of the contralateral eye in primary position, with the hypertropia increasing on contralateral gaze and contralateral head tilt. So in a patient with right inferior oblique muscle palsy, the left eye will be hypertropic in primary position, which will increase in left gaze and left head tilt. Being the main elevator of the eye in adduction, there will be deficient elevation of the affected eye in adduction, resembling Brown syndrome, and we will be discussing how to differentiate inferior oblique palsy from Brown syndrome when we discuss Brown syndrome. Secondary superior oblique overaction can occur in a patient with inferior oblique palsy, demonstrating a pattern and intorsion of the eyes. Indications for surgical treatment of an inferior oblique palsy is abnormal head position and significant vertical deviation with diplopia. And surgical options include weakening of the ipsilateral superior oblique muscle, the antagonist of the palsied ipsilateral inferior oblique muscle, or weakening of the contralateral superior rectus muscle, the yoke of the palsied ipsilateral inferior oblique muscle. So after discussing overactions and palsies of the oblique muscles, we now come to restriction of oblique muscles. In Brown syndrome, there is restricted elevation in adduction due to abnormalities in the tendon trochlea complex. Brown syndrome affects the right eye more commonly than the left eye, and females are more commonly affected than males. Brown syndrome can be bilateral in 10% of patients. Most cases of Brown syndrome are congenital. Acquired Brown syndrome can be due to peritrochlear or orbital trauma, iatrogenic following frontal sinus surgery, or superior oblique tucking which tightens the superior oblique muscle, post-inflammatory following orbital myositis, systemic inflammatory disease such as rheumatoid arthritis and sinusitis. In post-inflammatory etiology, the signs and symptoms can be intermittent, and space-occupying lesions such as orbital tumors and foreign bodies, including buckles and shunts. The most important clinical feature of Brown syndrome is restricted elevation in adduction, which is very important to remember. And when elevation is attempted in primary position or in abduction, the restriction to elevation decreases or disappears. Being a restriction, the limitation in ocular movement is similar in induction and version testing. Unlike in paralytic strabismus, where duction testing may show less limitation in motility of the affected eye as compared to version testing. An attempt at elevation from primary position may cause a V pattern due to lateral slippage of the globe when the globe attempts to elevate because it comes in contact with the tight superior oblique tendon. This photograph shows a patient with Brown syndrome of the left eye, and in the primary position the eyes are orthotropic, and when the left eye is adducted in the right lateral gaze and then an attempt is made to elevate both the eyes, the left eye does not elevate, but elevation of the left eye from the primary position and from the left gaze position are not deficient. Also, we find the V pattern between the straight down gaze, primary and straight up gaze positions. Severe cases can have hypotropia in primary position with the patient taking up a chin up or a contralateral head turn compensatory posture. The patient may hear or feel a click when he or she attempts to elevate the eye in adduction, and forced duction test demonstrates restricted elevation in adduction, which is accentuated when during the forced duction test the globe is pushed backwards, further tightening the superior oblique muscle. Forced duction test shows minimal restriction or is negative when the globe is elevated from the primary position or the abducted position. So we need to differentiate an inferior oblique palsy in which there will be weak elevation of the affected eye in adduction from Brown syndrome where there will be restricted elevation of the affected eye in adduction. In inferior oblique palsy, there will be superior oblique overaction which will result in intorsion and an A pattern, and the three-step test will be positive in inferior oblique palsy. However, the forced duction test will be negative in inferior oblique palsy, which will be positive in Brown syndrome. But in Brown syndrome, we will not find superior oblique overaction with torsion or A pattern, and the three-step test will be negative. However, in Brown syndrome, we may find a V pattern as we have just described. Mild congenital Brown syndrome may disappear spontaneously with time, and systemic inflammatory causes may require local or systemic anti-inflammatory treatment. Surgery is required when there is primary position hypotropia and chin up posture, and surgery usually involves lengthening of the superior oblique tendon with spacers. Other causes of vertical deviation with horizontal incomitance include skew deviations. In skew deviation, the hypertropic eye is encyclotorted and hypotropic eye is excyclotorted. But in superior oblique palsy, we find hypertropia with excyclotorsion of the hypertropic eye, and in inferior oblique palsy, we find hypotropia with encyclotorsion of the hypotropic eye. So the combination of hypertropia and encyclotorsion or hypotropia with excyclotorsion suggests skew deviation, whereas hypertropia with excyclotorsion and hypotropia with encyclotorsion suggests palsy of oblique muscles. And when a patient with horizontally incomitant vertical deviation is made to lie in the supine position, the vertical strabismus of skew deviation decreases because of altered vestibular inputs, but vertical deviation of oblique muscle palsies do not disappear. Other causes of horizontally incomitant vertical strabismus include third cranial nerve palsy with aberrant regeneration, thyroid eye disease, and orbital tumors and implants. But all this can also cause a horizontally comitant vertical strabismus more commonly, and so we'll discuss these entities in the next session. So to recap the salient points, vertical strabismus, torsional strabismus and pattern strabismus often coexist because all can arise from oblique muscle dysfunctions. Torsion can be detected by ophthalmoscopy, blind spot mapping, double Maddox rod test and Lancaster red green test. Vertical deviations due to oblique muscle dysfunctions are horizontally incomitant. Overdepression and overelevation in adduction are commonly caused by oblique muscle overactions, the superior oblique and the inferior oblique respectively, or cyclorotation of muscle pulleys, encyclorotation of the muscle pulleys and excyclorotation of the muscle pulleys respectively. And in cyclorotation of muscle pulleys, weakening of oblique muscles do not effectively correct overdepression or overelevation in adduction. Large angle exotropia and Duane's syndrome with upshoots and downshoots can demonstrate both overdepression and overelevation in adduction in the same eye at different points in time. Patients with inferior oblique overaction demonstrate overelevation in adduction, V pattern and excyclotorsion. V pattern and excyclotorsion are more prominent in bilateral inferior oblique overaction. In contrast to patients with superior oblique palsy who can have secondary overaction of the inferior oblique muscle, patients with primary inferior oblique overaction does not demonstrate hypertropia in primary gaze or positivity on three-step test, which are features of superior oblique palsy. Superior oblique overaction patients demonstrate overdepression in adduction, A pattern and encyclotorsion, with A pattern and encyclotorsion being more prominent in patients with bilateral superior oblique overaction. Superior oblique palsy is the most common single cyclovertical muscle palsy because it is the only cyclovertical muscle to be exclusively supplied by a cranial nerve, the fourth cranial nerve. In unilateral superior oblique palsy, patient will complain of vertical diplopia, have a compensatory contralateral head tilt, hypertropia of the affected eye in primary position, and a positive three-step test for the affected eye. In bilateral superior oblique palsy, patient may not have vertical diplopia because hypertropia of either eye may nullify each other, but may perceive encyclodiplopia because of significant excyclotropia because excyclotorsion of either eye is additive, and can also have a chin down position, significant V pattern and positive three-step test for both the eyes. Commonest cause of acquired superior oblique palsy is closed head trauma. Congenital superior oblique palsy may become symptomatic in childhood or later in adulthood. It is characterized by a head tilt in childhood, which may be found in old photographs of an adult patient, facial asymmetry, and large vertical fusion amplitudes. Brown syndrome is characterized by deficient elevation in an adducted position, and this deficiency in elevation decreases or disappears in an abducted position. Brown syndrome is due to restriction in the trochlear tendon complex of the superior oblique muscle. It can be congenital or acquired, and acquired cases of Brown syndrome occur following trauma to the tendon trochlear complex or following inflammation of the superior oblique tendon. Brown syndrome patients demonstrate positive force duction test for the superior oblique tendon, a V pattern, and these patients may perceive a click in the region of the tendon during elevation in adduction. Thank you for listening.